Hello and welcome everyone to another emergency questions and answers for families in intensive care and intensive care at home. I want to welcome you to the show. Also want to welcome anyone that's watching this on replay. I know there's always quite a few people that watch this on replay who can't make it live to the show. This is your opportunity to ask me questions here about anything related to if you have a family member in intensive care or intensive care at home. If not, I have many questions that I can go through that have come in during the week. And my name is Patrick Hutzel. I'm the host of the show. What makes me qualified to hold an emergency question and answers for families in ICU and intensive care at home? I'm a critical care nurse by background, having worked in critical care nursing for 25 years in 3 different countries, where I worked as a nurse manager for over 5 years. And we have been consulting and advocating for families in intensive care here at intensivecarehotline.com since 2013. And I can very confidently say that we have saved many lives for our clients in intensive care. And that is verified on our testimonial section at intensivecarehotline.com. And it is verified on our intensivecarehotline.com podcast section. So I'm also the founder and managing director of Intensive Care at Home. With Intensive Care at Home, we have been operating since 2012 all around Australia, where we send our critical care nurses into the home for predominantly long-term ventilated patients, adults and children with tracheostomies. We are also sending our critical care nurses into the home for any clients on a tracheostomy without ventilation, BiPAP, CPAP ventilation without tracheostomy, cough assist management, home TPN, central line, Hickman's line, peak line management, as well as port management at home. We are also providing ventilation weaning at home, palliative care services at home. We're also providing IV fluids at home, IV potassium and IV magnesium infusions at home. And again, you can look up our testimonials at intensivecarehome.com as well. We are having a critical care nursing workforce in the community that, we're bringing the highest skill level into the community with our critical care nursing workforce. We're employing hundreds of years of intensive care nursing experience combined. No other service provider can match that skill level that we are providing in the community than we can. With intensive care at home, we're also providing level 2 and level 3 NDIS support coordination. Okay, let's go to some questions that have come in throughout the week. The first question that's come in throughout the week is, yes, I did make a video the other day about the tragic loss of Grace Scara. And, there was a court case in the US in Wisconsin last week, or it's been going on for quite a few months now. And, the family claimed that their daughter was killed, by the ICU at the time during COVID. And they said there was an illegal DNR. And the family claimed that, she was getting too many sedatives such as lorazepam, Presidex, and also opiates such as morphine, and that is what killed her. The court case just concluded last Friday, and from what I understand from media reports, is the courts actually sided in favor of the hospital. Now, I don't know the ins and outs, but I think it's quite an important case. I had Scott Scara, Grace's dad, on my podcast here a couple of years ago to talk about his case. So now that has come to an end with a court case. It's very sad, I believe, but, I have not seen any medical records, so I can only go by what, Scott Scara has said on his podcast and what he said on my podcast. But at this particular point in time, the court sided with the hospital. I'm not sure whether the family, will consider the case and potentially challenge the courts and the hospital again, if that's a possibility even. I don't know. But yeah, at this point in time, the courts have sided with the hospitals. So then another question that has come in from Bob during the week is, I'm preparing for my heart surgery after the loss of a loved one after his heart surgery. Yes, so Bob, all I can tell you here is you should be preparing for open heart surgery. You should be talking to your cardiac surgeon. You should be talking to the anaesthetist. You should be asking, obviously, if there's any other situations that, or anything that is sort of important for your open heart surgery. What are the risks? What are the benefits? Of course, you know, how many days are they expecting you to stay in ICU? You know, is it open heart surgery for bypass grafts? Is it open heart surgery for valve repair, valve replacement? You know, those are the questions here that you might want to consider asking. What's the post-surgical plan? 1 day ICU, 2 days ICU, potentially even longer. Do you have any other pre-medical conditions that could impact on the outcome of the open heart surgery? You know, for example, do you have kidney disease? Do you have liver disease? You know, do you have any respiratory issues which could prolong your time you need a ventilator for? All these questions you should be asking. And also, have you had an angiogram? Have you had an angiogram? Have you had an ultrasound of the heart? What's precluding the cardiologist to send you to a cardiac surgeon to do cardiac surgery? Right? So those are issues you need to consider. You know. So what happens when your heart surgery is coming up, but you just lost a loved one after their heart surgery? You know, that's quite frightening. It is very confronting and a very emotional experience, because you're dealing with fear, grief, uncertainty, and now your own health crisis. You know, and I've seen this many times in ICU. You know, a wife loses her husband after bypass surgery, and now she's told she needs the same operation. A son buries his dad after valve replacement, only to find out he's got the same genetic condition. It's devastating. So, you know, how do you prepare physically, emotionally, mentally, when your heart and your life is on the line and your mind is still grieving? So let me walk you through it step by step. The number one thing is you acknowledge your fear and your grief, which is what you're doing. It's okay to feel scared. It's okay to feel vulnerable. You're not weak, you're human. Grief takes a massive toll on the body and mind. Don't ignore it. Bring it up with your doctors, bring it up with your support team. You don't have to pretend to be strong when you're facing something this big. And don't let others rush you. You'll be fine, they say, but only you know the weight you are carrying. Next, separate the medical facts from the emotional fallout. So your loved one died after heart surgery, but that doesn't necessarily mean you will, because every case is different age, different conditions, different hospital, different ICU, different surgeons, different level of care, different decisions to make before and after surgery. You know, I've worked with thousands of families of critically ill patients in intensive care and with intensive care at home who were told there's no hope, only to see their loved one recover when the right care decisions and advocacy were in place. You need to look at the data and your individual case, not the trauma of what happened to someone else. That trauma is real, but it's not a medical diagnosis. Get a second opinion. If you don't feel confident in the medical team you've been assigned, change it, period. Just because a hospital is offering you surgery doesn't mean it's the best place for you. It also doesn't mean that you need surgery. Maybe your loved one, he didn't get the care he deserved. Maybe he was neglected. Maybe the ICU pushed for withdrawal of treatment too early and you didn't know how to stop it. Now's the time to advocate loudly for yourself. And if you need help, that's where we come in. At intensivecarehotline.com, we guide families every single day who are faced with these impossible decisions. Many of them are exactly where you are right now. Also, put your support system in place. Don't go into surgery alone, physically or emotionally. Have someone with you who can advocate for you post-surgery. Make sure they know your wishes. Make sure they understand ICU, because here's the truth. ICU teams often push their own agenda. They may tell your family there's nothing more they can do, and when in fact there are options, but only if you know how to push back. Have someone like us by your side, almost on standby. And prepare for the ICU experience. Expect it, plan for it. If your heart surgery is major, such as coronary artery bypass grafts, valve replacement, or aortic dissection, whatever it may be, you'll likely end up in ICU. Here's what you need to plan for. Will you be ventilated after surgery? If so, for how long? What are the risks of if you need a tracheostomy? You can't come off the ventilator if you can't be extubated. What's your family's plan if the doctor suggests a DNR or want to withdraw care and treatment? Do you want intensive care at home if you want to be weaned off the ventilator? Do you want that at home? Don't wait until you're sedated and voiceless to think about these decisions. Make them beforehand and make sure your family knows your values, your rights, and your choices. Right? How long will you have chest drains in place? Right? How long will you need pain medications for? Right? Will you need a pacemaker after surgery, even if it's only temporary? How long will the surgery go for? Right? What are the risks after surgery? Such as bleeding, DVT, because preparing for heart surgery is already scary. Preparing for heart surgery after losing someone in ICU is traumatic. But here's the truth. No one tells you. You can take back control. You can plan. You can advocate. You can ask the right questions, and you can refuse to let history repeat itself. And if you need help with any of this, of course, reach out here to us at intensivecarehotline.com, because that is what we are here for, families in intensive care. So, here's another question that I had from a reader this week. He said, my girlfriend died because she pulled out her ventilator tube. Now, and I did actually speak to this particular person on the phone this week. Now, that is very hard to believe. Obviously, he wasn't there when it happened. Nobody from the family was there when it happened. The ICU says that the lady pulled out her breathing tube and she died. Now, that I find very hard to believe, because she went into ICU for a routine surgery. And then, do people pull out their breathing tube? Yes, they do. But it is often by mistake, and then the breathing tube should just go back in, right? And the breathing tube should just go back in. That's it. Have I seen patients pulling out their own breathing tube? Yes, I have. I absolutely have. And then if they're not ready to breathe, the intensive care team will put it back in. Now, other scenarios that could lead to a patient losing their breathing tube when they're not ready for it is, when patients get turned on their side to get their backs washed, to get their backs washed, to get linen changed, pressure area care. That is also a high risk situation where the breathing tube could come out. There's also other situations where, if a patient goes for an MRI scan, for a CT scan, and they're being moved around in the CT or MRI scanner, that is also a high risk for a breathing tube to come out, right? So it can happen during those situations. But for your girlfriend to have the breathing, or to remove the breathing tube herself and then die, that doesn't sound right to me. And just because someone pulls out their breathing tube, I have not seen anybody die, because what happens if the patient needs the breathing tube back in, the intensive care team will just put it back in, will do a re-intubation, right? That's the bottom line. So, that also should have been a coroner's case, I would think. Also, you mentioned that your girlfriend was 44 years of age, so very young. So, it doesn't sound right to me. That much I can tell you. It does not sound right to me. What's happened there? Absolutely not. And you need to get access to the medical records. You need to get access to the medical records. You need to do a deep dive here, because that screams negligence to me. That screams negligence to me. Okay, I also have a testimonial from this week that came in, and that reads like from Maeve. She says, thanks to you, Patrick, and the intensivecarehotline.com. My husband is now home and more stable. I found these emails so helpful while navigating my husband's care in the hospital, and you've helped us point things the hospital missed. I appreciate you, Patrick, and the intensive care hotline team very much. From Maeve. This was actually is one of our members, and her husband has been in ICU for months and months on end after a lung transplant, actually. Then other questions that have come in during the week. Are a email from Sarah, who says, hi Patrick, thanks a lot for your useful website intensivecarehotline.com. An elderly member of my family is in a coma induced by a brain stroke. He's in ICU now and is on a ventilator. Upon arrival, the hospital made a CT. But now the ICU team is insisting on the CT being very dangerous since he's on a ventilator. Also, they keep saying that moving him can be fatal and the CT is not necessary because the caring procedure will remain the same even if bleeding is still ongoing. What should we be doing? Well, Sarah, I'm very sorry to hear about your family member situation, right? So just like I said in my last example, where, you know, Michael said his girlfriend pulled out a breathing tube and she died, it is to a degree the same. That, you know, a CT scan is dangerous for having the breathing tube removed. It can be dangerous. However, you know, that that doesn't stop anyone from going for a CT scan or for an MRI scan. You know, it just needs the right manpower. That's all it is, right? And very timely here, Tom. Hi, Tom. Nice to see you again. Just 48 hours ago, my son went to a CT and he was disconnected from the ventilator during the procedure. I was called to help and his SATs was 56%. He was blue, but I reconnected the ventilator and he recovered. Sad that nurse could not properly manage the ventilator. It was our travel ventilator. Just reinforcing what you were saying about disconnecting during CT or MRI. Yes, absolutely. I'm very sorry to hear that, Tom, and I know you're a regular viewer here. That is, yeah, those are the dangerous situations, you know. Those are the dangerous situations, making sure that ventilator is always connected, you know. Making sure that that ventilator is always connected and making sure you've got the right skills on site, because that's what it all comes down to, having the right skills on site, you know. So, I hope your son is okay, Scott. Tom, sorry, I hope your son is okay, Tom. But if his SATs was down to 56%, that's very, very dangerous. He could have easily gone into cardiac arrest. You know, that's why I keep saying over and over again, you need critical care nurses to manage ventilators and tracheostomies, nothing else. You know, that just confirms that. You know, so coming back to Sarah's email, you know, where the ICU said they shouldn't be going for another CT scan. It's potentially being fatal, and the CT is not necessary because the caring procedure will remain the same even if bleeding is still going on. Well, ICU says moving the patient is dangerous, CT is unnecessary as treatment wouldn't change, CT could be fatal. Right, so first of all, CT scans are standard for stroke monitoring. Repeat CT scans are absolutely standard to monitor. Ongoing or worsening bleeding, especially for hemorrhagic stroke, brain swelling for edema, hydrocephalus fluid buildup, ischemic stroke conversion to hemorrhagic stroke. CTs guide treatment decisions such as whether surgery is needed, such as decompression, evacuation of bleed, escalation or de-escalation of care, and prognostic indicators, right? So, for example, a CT might also determine whether there's brain pressure, does he need potentially an EVD or an ICP, EVD and extraventricular drain, ICP and intracranial pressure monitoring to check the brain pressure. Next, which is what I said before, ventilated patients can be safely transported for CT. Transporting ventilated patients for CT is done routinely in ICU, which is why I said, in Michael's case earlier, even if, his girlfriend went for a CT scan and they, by mistake, extubated her, took the breathing tube out, that still should have not stopped, the ICU from reintubating her. That should have not resulted in your girlfriend dying. Next, yes, it carries some risk, blood pressure drops, oxygen desaturation, but ICU teams are trained to manage it. It's typically done with portable monitors, ICU nurse, respiratory therapist, and even a doctor if needed. Right? And I can tell you, there is a doctor with for transport always. Refusing CT is withholding crucial information. Saying care won't change is often used as an excuse when the team has already decided on a limited treatment plan, right? So, again, that's why you're doing the right thing to push for that. If you haven't signed any DNRs or limitations of care treatment documents, you have the right to insist on full diagnostic. A repeat CT could show if bleeding has stopped, worsened, or needs surgery. Without it, you're flying blind. What you can do: ask the questions directly. If he's too unstable to go for a CT scan, is he too unstable to stay alive? Has a neurologist or neurosurgeon seen him recently? Is there a portable CT option? Can you guarantee that not doing a CT won't lead to missed treatable complications like brain herniation or hydrocephalus? Are you suggesting palliative care without involving the family? Right? This is what I'm saying. If you can't read between the lines, you're fighting an uphill battle. You might just simply believe what they're saying. Next, insist on the CT scan if you want full care. Say, we understand there are risks with transport, but we believe the benefits of knowing the current brain status outweigh the risks. We are not ready to limit treatment, and we need updated imaging to make informed decisions. Next, ask for a second opinion from the neurology or neurosurgery team, or you could request an ethics consult if you trust the ethics team there, especially if you feel the team is nudging towards withdrawal of treatment. However, ethics teams in hospitals and in ICUs in particular are biased. They are hospital employees. They won't be doing what they will be doing what hospitals want, because their career, the people on the ethics committee's career path depend on that. Their careers depend on what they say. So ethics committees are flawed in my mind. In my extensive experience, they are flawed, and they are not the best path to choose. Your best path is towards advocacy. Red flags you should watch for: CT won't change anything. They may have given up. It's too risky, often overused to block tests that might reveal treatable problems. Lack of imaging, you lose power to question or confirm the prognosis. No neurologist input is substandard stroke care. The bottom line is, you have every right to advocate for your loved one. Don't accept vague explanations. A CT is not just a diagnostic tool, it's a decision-making foundation in stroke management. If the ICU refuses and you're not satisfied, ask for a hospital liaison, patient advocate like we do here at intensivecarehotline.com, or even consider transferring to another ICU if needed and feasible. Very simple. So, Tom, it's very good to hear that your son is doing okay, that's really important to know. So coming back to the situation that I've just explained about Sarah's situation, to keep advocating for a family member. And I also give you a sample statement so that you can write or say to the ICU team. To the ICU team, we are deeply concerned about our loved one's condition following the stroke and his current status on the ventilator. We understand that he had a CT scan upon admission, but we believe a follow-up CT is absolutely necessary to evaluate whether the stroke has progressed, if there's ongoing bleeding, swelling, hydrocephalus, or any other complications. We are aware that transporting a ventilated patient carries some risk, but we also know that such transports are routinely and safely performed in ICUs all over the world. The benefits of having updated information about the brain, which is critical for making appropriate medical decisions, outweigh the risks in this case. We are not ready to withhold or withdraw any form of treatment. We want full care and full diagnostic clarity at this stage. Without updated imaging, we feel that crucial decisions could be made blindly, and we cannot allow that. We therefore respectfully request a repeat CT scan of the brain as soon as medically feasible, input from a neurologist or neurosurgeon if not already involved, a clear written explanation if this request is being denied, including who's making that decision and why. We are committed to making informed, responsible decisions in the best interest of our loved one, and we ask for your collaboration in achieving that. Very simple. The other thing that I always say is do not overcomplicate. Just call it for what it is. You can present this during a family meeting or ask the nurse to pass it to the ICU consultant on duty. If they push back, ask for a meeting, or escalate it to hospital executive, which is what we are doing here at intensivecarehotline.com. We're constantly escalating things to hospital executive. We're constantly doing that because that's what we're good at and that's what we do. Now, and it's interesting, Tom, that just as I was giving this example, you had your own experience not even 48 hours ago. It just goes to show the risk of what's happening. Just goes to show the risk. Okay, next thing I want to talk about is, how to reverse a DNR in intensive care within less than 24 hours, because, again, we've got a proven track record of that. Reversing a do not resuscitate order in an intensive care unit within 24 hours is absolutely possible, but it requires swift, clear communication. Here is how you can do it. And just let me set the scene. DNRs, generally speaking, are, without patient or family consent, are illegal, right? So just to put that out there as a starting point, that in most countries, issuing a DNR by the ICU team, without patient or family consent is simply illegal. So number one, as soon as you think that is what's happening, you need to notify the ICU medical team immediately. Tell the ICU doctor or nurse in charge that you or the legal decision maker want to reverse the DNR. Use clear language like, I'm revoking the DNR order effective immediately. Please document this in the chart now. Number two, request documentation. Ask the ICU team to document your request in the patient's medical records immediately. Request a written or verbal confirmation that the DNR has been cancelled, and verify the patient's decision-making status. If the patient is conscious and competent, only they can reverse the DNR. If you are the medical power of attorney, legal guardian, or next of kin, you can make this decision if the patient lacks capacity. Provide legal documents if needed. If the hospital asks for proof of your authority, show the advance directive, power of attorney, or legal guardianship papers. If you don't have the paperwork immediately, insist the change be made while you locate the documents. Next, demand immediate chart update. Please update the orders now and remove the DNR code from the chart and wristband. I'll wait until it's done. ICU teams typically update electronic health records in real time. Confirm the code status. Ask the nurse, can you confirm the current code status on the chart? You should hear full code if the DNR has been reversed. Follow up in writing. Send an email or fax to the hospital stating you are reversing the DNR, the date and time, your name and relationship to the patient. Request a written acknowledgement. Here is what's important. DNR orders are not permanent. They can be revoked at any time by the patient or their legal surrogate. In emergency situations, make your request firm and urgent. Hospitals cannot legally refuse to reverse a DNR if a valid surrogate or patient revokes it. Very clear and simple. Don't let anybody else dictate you otherwise. So that is really important for you to know. You know, most families in intensive care simply don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. Right? They don't know what they don't know. So, next question comes from Jarvis, who says, "Hi Patrick, my mother has given up and gets angry when I beg her to seek a specialist to treat septicemia. She's going to die in a nursing home with no treatment, and she does not care. She was not suicidal before this. Is this a feature of sepsis? What to do? Watch her die?" Wow, that's a really good question here from Jarvis, and I'm very sorry to hear about your mother's situation. You know, it's heartbreaking to watch someone you love seemingly give up, especially when it feels like something could still be done. So the mental changes you're describing can absolutely be a symptom of sepsis, especially in older adults. Sepsis can cause delirium, confusion, apathy, emotional changes, and even what looks like depression or suicidal behavior. Even in someone who has never acted this way before. This isn't necessarily your mother's true self. It may be the infection affecting her brain and body. Why this happens in sepsis? It's an inflammatory response. Sepsis floods the body with inflammatory chemicals that can cross the blood-brain barrier and impact brain functions. Organ dysfunction. When sepsis affects the liver, kidneys, or other organs, toxins can build up and affect mental clarity. Low oxygen or blood pressure, reduced blood flow to the brain can alter mood and thinking. Delirium or septic encephalopathy, common in older patients with sepsis, leading to withdrawal, agitation, or unusual emotional reactions. What you can do. Here are urgent practical steps you can take. Call a doctor immediately. If she's in a nursing home and has suspected or known septicemia or sepsis and is not being treated, this is a medical emergency. Insist on immediate transfers to hospital or emergency room for IV antibiotics and fluids. Sepsis is treatable, especially if caught early. You can call an ambulance directly if needed. Get her assessed for capacity. If her decision to refuse care is based on sepsis-related confusion or mental change, she may not have the capacity to refuse treatment right now. Ask for a formal capacity assessment by a doctor, geriatrician, or a psychiatrist. If she's found to lack capacity, you or another family member may be able to make decisions on her behalf. Push for hospital admission. Many nursing homes underplay sepsis or avoid hospital transfers. Be firm. Say that she's showing signs of sepsis and possibly delirium and needs urgent hospital care. If they refuse, request a second opinion or speak to the after-hours on-call doctor or ambulance service directly. Appeal to her emotionally if she's still partially lucid. Say, "Mom, I know you're tired, but I don't believe this is you talking. It's the infection. Let us help you get through this. I can't bear to lose you when there's still a chance to turn this around." And you certainly don't have to accept this as her fate. If you're being told by staff that nothing can be done, you can call a patient advocate, the Aged Care Quality and Safety Commission if you're in Australia, or even an ambulance yourself and explain the suspected sepsis with altered mental states. This may be temporary medically induced apathy, not a real decision to give up with sepsis. Time is everything. The faster treatment starts, the better the outcome. Please don't let this go unchecked. You have every right to intervene and push hard. You know, like with everything, Sun comes up in the morning, sun goes down at night, sun comes up the next day again. Never, ever give up. She might just need proper treatment in hospital, and then things might turn around again. Okay, let's move on to the next question. That is more like a testimony as well. I've been watching you for years. I thank you from the bottom of my heart for your genuine videos. They're truly life-changing. That is from a subscriber on YouTube with the username MamaTried925. So thank you for those kind words. I really appreciate it. So then, next question. My mum is in ICU now since yesterday morning. My brother was there to give her CPR after cardiac arrest. The ambulance came after 5 minutes and it took 20 minutes to get a pulse. She has kidney failure and a high potassium. Her vitals are almost normal, but she hasn't woken up yet. They said if she goes into cardiac arrest while on dialysis, then they'll pull the plug. So, I'm very sorry that you are going through this. You've been facing so many incredibly hard situations, and now your mother is in the ICU after another cardiac arrest. It is heartbreaking. Based on what you've shared, here's a breakdown of the situation and some thoughts to help you navigate it. Medical summary. Cardiac arrest, your mother lost her pulse and was without circulation for about 20 minutes. That is a long time, and it raises concerns about possible anoxic brain injury from lack of oxygen. CPR and ambulance response. Your brother starting CPR quickly may have helped preserve some brain function, but it's still too soon to tell. Hypotassium, also known as hyperkalemia, and kidney failure. These can both contribute to cardiac arrest. Dialysis is typically used to lower potassium and stabilize her. Vitals are almost normal. That's promising. It means her heart and blood pressure are stable for now, but not waking up yet is concerning. If the ICU team says they'll withdraw care and treatment if she codes during dialysis, that's a red flag. You have every right to ask questions about the decision and push back if it doesn't sit right with you. Questions to ask the ICU team right now. Number 1, neurological status. Has she had a CT or MRI scan of the brain? Are they doing neurological assessments, pupil response, motor response? What is her current Glasgow Coma Scale or GCS score? Are they doing continuous dialysis or planning regular hemodialysis? What are the risks of dialysis in her current condition, and how are they preparing to manage them? DNR code status. Who made the decision about pulling the plug and if she arrests? If she arrests during dialysis, I've got Adam here. And I've got Adam coming.
Hello, how are you?
I'm very well, thank you. How are you?
I'm good. So you're the incentive to care for this and that. That's what
We're helping families in intensive care.
Wrong with my
Do you?
iPad? There we go. So it's just like something that you talk about, like intensive to care.
That's right. Do you have a family member in
So
intensive care?
I'm trying to download the app. Anyway, never mind. Anyway, but the intensive care is very good. Very good. I love this app, by the way. No, like
How can I help you, Adam? Do you
I
have
mean
a
this.
question?
What should I say? So what's happened? Like what you were talking about? I want to hear what you were talking about. So I just want to join and hear what you're talking about. So just what I want to do. So that's why.
You can listen. Okay. Do you have a family member in intensive care, and do you need help right now?
Your screen keeps loading. Hold on, I'm coming back. I need to download the app. Give me 1 minute. 1 minute. I will download the app.
Okay. Let's get back to the email. Where were we? Yes. So, what's her current Glasgow Coma Scale? Are they doing continuous dialysis, CRRT, or planning regular hemodialysis? What are the risks of dialysis in their current condition? And how are they preparing to manage them? DNR code status, who made the decision about pulling the plug if she arrests during dialysis? If she currently listed as full code DNR, do not resuscitate, or DNR, do not intubate. Did the family consent to this? If not, ask them to stop and explain all options before making assumptions. Number 4, prognosis and monitoring. How long are they willing to observe her for signs of neurological recovery? Are they doing EEG or other tests to check for seizure activity or brain function? You and your family have the right to ask for a second opinion, especially from a neurologist and nephrologist. Refuse withdrawal of care unless you're fully informed and in agreement. Request a family meeting with all key specialists, ICU doctors, nephrologists, neurologists, case managers. If you feel pressure to agree to end care and treatment, document who said what and when, and ask for things in writing when possible. What you can do right now, gather the family and decide what your mother would want. Has she ever said anything about life support, dialysis, or resuscitation? Ask for updates every few hours. Don't wait for them to come to you. Make it clear that you are not ready to withdraw care and treatment unless there's overwhelming and clear medical evidence, and even then only after a full medical discussion.
Yay, I'm
Adam,
back. I'm here. Yeah, I'm back. Sorry. It looks like that. I was trying to download the app and it didn't work because I was
okay,
trying
Adam,
to sign in with.
how can I help you? How can I help you? Come to the point.
What did he say?
How can I help you? Do you have any questions? Do you have a family member in intensive care?
Yeah, I do have some questions.
I don't think you are genuine here. I'll take you off the stage. I don't think you're genuine. Thank you.
Yeah, so my mom is always upset because we have my that's terrible. My kid's screen keeps glitching. Give me 1 minute. It keeps glitching. 1 second.
No, I'll kick you off. I'll kick you off. So if you come on stage here, please be sincere and genuine. So you know the stage is reserved for people who really need help. So, okay, so what else is there? Okay, here's another email from another Sarah. Hi, Patrick. They are mentioning putting my 71-year-old mum in an acute care rehab. She had a spinal cord injury and paralyzed from the chest down. She was intubated and had a tracheostomy. They're trying to wean her from the ventilator, but only have 4 hours of success of it. Your article says a long-term acute care facility should be avoided. She's on Medicare. The hospital says it will provide better rehabilitation for her. So I argue that number one, it sounds to me like you're in the US, right? If she's paralyzed from the chest down, she now has a tracheostomy. They're trying her off the ventilator. The hospital says it will provide better rehab for her. No, they won't. No, they won't. They won't, and it'll only go from bad to worse. Your best option here is to go home with intensive care at home. That is your best option, right? That is your best option. Because, you know, from my extensive experience, going from ICU to LDAC in the US is just not a good idea, right? And it means that, you know, her care will go from bad to worse. Her care will go from bad to worse, right? And, you know, I've done so many videos about patients going from ICU to LDAC, how it turns out. It never turns out well. It never turns out well, right? So because before your mom goes to an LTAC, right, especially with a spinal injury, you know, she needs to be stabilized. And when you go from ICU to LTAC, for example, there is not much LTAC can do, right? Everything that should be done should be happening in an ICU or in an intensive care at home setting, but not in an LTAC, right? Kaylin says, my mother-in-law inquired last August, but I'm different story. It's my old man, it's my fiance. My daughter's, what are you saying? It's my old man, it's my fiance. My daughter's dad, can you please contact me? I'm so sorry for everything everyone is going through. Thankful for this channel. I don't know what you are referring to there, Kaylin. My mother-in-law inquired last August. We have so many people inquiring. I could not remember your mother-in-law's inquiry. Can you be more precise on what you're inquiring about? Right? Can you please be more precise, Kaylin? That would be really good if you can be more precise about what you're exactly inquiring about. Okay, in any case, coming back to Sarah's email, it is not good to have your mum go from ICU to LTAC with a spinal injury. She already made the inquiry and said she was supposed to send in the records for review, and she asked questions before she sent in the records, questions, answers. Sure, that's fine, Kaylin. We have so many clients doing that. So unfortunately, I do not remember your mother-in-law's specific case, or, you know, do you have her name? What was your mother-in-law's name? You know, can you be more specific? Right. So coming back to Sarah's email, it's absolutely critical that you challenge the recommendation of moving to a long-term acute care facility, despite what the hospital claims about long-term acute care facilities. Here's the reality they're not telling you. Your mom is not medically stable if she's not weaned off the ventilator yet. LTACs are not equipped like ICUs. They don't have the same nurse-to-patient ratio. Respiratory therapists in the US around the clock, intensivist oversight, intensive care nurses that are actually ventilator and tracheostomy competent. If your mom has only tolerated 4 hours off the ventilator, she's at high risk of ventilator failure, aspiration, or respiratory distress at an LTAC. Even Medicare guidelines typically require a patient to be medically stable before discharge to an LTAC. If she's still needing active weaning and complex respiratory care, she's not stable. Right? Also, you lose continuity and oversight of care in LTACs. Once she leaves ICU, her access to critical care doctors, critical care nurses, timely imaging, timely diagnostics, and emergency intervention is reduced, if not gone altogether. If something goes wrong, like a pneumonia, mucus plugging, or another infection, LTACs often transfer patients back to ICU after deterioration. Acute rehab facilities are not designed for ventilated patients with tracheostomies. Rehabilitation hospitals typically require patients to be medically stable, able to tolerate 3 hours of rehab per day, and off the ventilator, or at least very close to complete weaning. If your mom is paralyzed from the chest down and ventilator dependent, she may not qualify or benefit from acute rehab just as yet. They may rush the decision just to clear the ICU bed. You know, what should you be doing instead? Keep her in ICU or step down ICU until fully weaned, until she's stable enough to go home with intensive care at home, if available in your area, or go to a high-level rehab that has ICU-level respiratory support, rare but possible. Push for a care conference, family conference with ICU doctors, ICU nurses, respiratory therapists, physical medicine rehab doctor, case manager. Demand a clear plan for ventilator weaning before discharge to an LTAC is considered. And like I said, I would not let her go to an LTAC at all. Ask for time. Medicare doesn't mandate discharge if the patient is still receiving daily acute care. The hospital may pressure you, but you can appeal any discharge plan that you feel is unsafe or not in the best interest of your mum. Kaylin, you're saying your mother-in-law was Natalia Knapp. Anyway, my fiance had a blood clot in his leg, went to his lung, and he had pulmonary embolism, and at 29 years old, taken off life support. End of life, he survived, 99% oxygen. Wow. I do remember Natalia, I do. So this is your, how are you related to mother-in-law's inquiry last August? Yeah, I do remember Natalia. Anyway, my fiance had a blood clot in his leg, went to his lung, and he had pulmonary embolism, and at 29 years old, taken off life support for end of life. He survived, 99% oxygen. That's fantastic. That is fantastic. And it's another survival story here. And it's another story where, you know, you should go with your gut. You know, did you advocate for your fiance? They also put him in for a brain scan with EEG band plus clips in his head, and it burned burrow holes in his head. Wow. He's still alive. That's fantastic. That is fantastic. Well done. And it's another survival story. You know, it's another story here that families need to hear, that, you know, if you had given up Kaylin, he probably would be dead. Is that fair to say? If you hadn't advocated for him, it's probably fair to say that he would be dead. You know? Very good and well done. Well done. So, coming back to Sarah's email, you know, it's your mother's life. ICU teams often push to move patients along for bed space, for financial pressures, not necessarily for the patient's best outcome. And unfortunately, LTACs often become warehouses for ventilated patients, with far worse outcomes than patients who are weaned and rehabilitated in a safe, controlled environment. That's the bottom line. I've made a video, a YouTube live a while ago, 10 reasons why LTACs in the US are a scam. And I am not changing any word that I said there. You know, unfortunately, that's reality. And it's good that you've advocated here, Sarah. It's good that you bring it to our attention here, because that is what you need to do for your mom's sake. You know, and the best option in the long run, if she can't be weaned off the ventilator, is intensive care at home. Now, the best place to be weaned off the ventilator is in ICU. If that can't be achieved, then you should be absolutely looking at intensive care at home with much gusto, you know. So, next. Next question, or, you know, Kaylin, do you have anything to add here? Thank you for sharing. That was really good. That was really good for you to share, and thank you for sharing. And I hope many other families see your and hear your story of survival. You know, that's what families in intensive care need to hear. So, then, next question. We have time for one more question from Corey, who says, my brother is dealing with the same. He went to ICU for a routine ankle surgery. He was supposed to come home after 7 days. On day 6, he went into cardiac arrest. It was so unexpected. He's on day 7. He's not acting right at all. He did nothing the first 5 days and when they would lower the sedation to do breathing trials. He wouldn't breathe without the ventilator. Now, the last couple of days, he started breathing the full 3 hours by himself until he gets worked up and starts breathing with his stomach. When he opens his eyes, they're looking up and off to the right, and his eyelids blink repeatedly, but he doesn't follow commands. What's strange is the EEG shows a brain that's symmetric and reactive to stimuli like lights, and the MRI shows no infarct, hemorrhage, blood clot, signs of stroke, or signs of brain damage from lack of oxygen. The EEG does show continuous slowing and encephalopathy. It's day 7, and we were wondering when he's going to wake up and if he's going to be okay. Any advice would be great. Now, first of all, you should never give up, right? As you've just heard here from Kayleen, you know, if she had given up on her fiance, he would be dead by now, you know. And just because someone is not waking up right now doesn't mean they're not going to wake up again. What it means is they haven't woken up just as yet, right? So don't give up. Patients in ICU wake up in their own time. Sometimes that might be days, sometimes that might be weeks, sometimes that might be months. If you let the ICU team withdraw treatment, you know the outcome. You know that your loved one is going to die. If you know the outcome is death, then why would you not keep advocating for a different outcome? Because you don't know the outcome if they keep going, but you know your brother will have a chance, right? And also, even though he hasn't woken up yet, at least he's now starting to breathe for himself, you know, so that's a good thing. That's a really good thing, you know. And also the EEG and the brain shows that a brain that's symmetric and reactive to stimuli. There's no infarct in the MRI, no hemorrhage, blood clot, signs of stroke, or nothing, right? So you need to be patient here. It's only day 7. It's only day 7, right? Give him the time he needs, you know, and very few patients in ICU wake up in a time that's convenient for ICU team. They wake up, you know, in their own time. They wake up in their own time. It's as simple as that. And they need to be patient. They need to be doing all the right things. Ask the neurologists as well, you know, what they are saying. Always ask a neurologist in a situation like that. Okay, so I'm going to wrap this up for today. Thank you for watching. If you like the videos, subscribe to my YouTube channel for regular updates for families in intensive care and intensive care at home. Click the like button, click the notification bell, share the videos with anyone you think you will benefit from this video, and tune in for any updates during the week. Go and check out intensivecarehotline.com if you have a family member in intensive care, and if you need intensive care at home, go and check out intensivecareathome.com. Thank you so much for watching. Have a wonderful week, and I'll be back again next week. Take care for now.